Attendees are in listen-only mode.
Good afternoon. Today is Tuesday, April 2nd. The Developmental Disabilities Administration welcomes you to the DDA Educational Series. Today's topic is Person-Centered Plan Authorization Process. Before we begin, I'd like to go over a few things about the webinar. This webinar is open to all stakeholders and will be recorded and put on the DDA website. All participants will be in listen-only mode. There are two options for listening to the webinar, by computer and by phone, and if you have trouble hearing, you can switch at any time by clicking the appropriate button on the webinar panel. There are handouts for this webinar and for last webinar, which you can access in the handout section on the panel. They also can be emailed if you would like to get them. You can email me, Donna Will, at donna.will@maryland.gov. We will be recording today's webinar and we will send the link in a follow-up email that will go out to all who registered. Questions can be typed in the question box, which is in the webinar panel, and they will be read and answered as long as they relate to the topic of person-centered plans. So, without further ado, I'd like to introduce Patricia Sestoki, DDA's Director of Programs.
Thank you, Donna. Appreciate the introduction. With me today, I have our Director of Federal Programs, Rhonda Workman, and we're hoping that today we're able to give you some clarity and information on how the DDA approves the person-centered plans. Just as an overview for today, we're going to go over our agenda, and we're going to be going over our DDA overview, the person-centered plan overview, and the authorization process. And this is going to go into detail of how DDA reviews, assess, clarifies, consults, and makes their final determination when a plan is submitted by the CCS to the regional offices. As always, we will start with our wonderful belief and acknowledgement that all people have the right to live, work, learn, play, and pursue their life and aspirations in the community. We've shared this in our webinars, or today is our third one, and I don't want to take the time to go through this, but really it's something that we believe in. It's something that we walk the path. We really want to make sure that our policy guidance and processes really take into consideration people with disabilities, families, to make sure that we have an inclusive, productive, and integrative system that is empowering of people with developmental disabilities across the lifespan. We serve, as you know, children, adults, and families. And then before we get started into a webinar, I want to make sure that we're all grounded as to why is it that we're doing this. So if you've been following us in our brown bag lunch hour, that we really thank you for taking the time of your busy day to engage with us. It's really the basic value and concept of what we're trying to do. And it's not for us, but it's for the people in our services. What is the trajectory to a good life? What does that really mean? And so if you, on the left-hand side of your screen, you see the integrated start, the integrated supports that we talked about in the last presentation. And it's really something that we value and we support. We want that person to be that start, that center, and then the supports around that person are not just eligibility. So we want the good life to be about employment, community, membership, home ownership, people being with their faith, with friends, to have a vacation, to do all the, and we really want to avoid eligibility specific supports. And somebody says, what does that really mean? Well, we mean that the life of the person only interacts and has a fulfillment with everything that is operated either by state service or something that is done by the state plan or by other state agency. We really want people to be able to not be lonely, to be isolated, or to have restrictions, or to ensure they have more freedom. So we really, this is really the goal of our person-centered planning. And so with this, we then go into how to then this DDA make a determination on services based on what the person assessed need is. The next slide that I'm sharing is just information about where your regional directors are and what counties we serve. And we put this on here because after this presentation and throughout the presentation, we're going to be talking about what the regional offices will be doing and how they make the determination. And so as you get more information and you get more involved, then knowledge is power, and it makes a better person center plan, and we want you to know who to go to and where to go to for that. So the focus of our person-centered plan overview, as we stated in the last webinar, is that the person-centered plan is the central part of the DDA services. We don't do anything without having that plan. And in that plan, we wanted to make sure that it's comprehensive and it really looks at the person assessed need and make sure that through the waiver and through the services, we can address that person assessed need. We not only look at that, but we also look to see what other supports and services the person is receiving from either their family, the community, their local county, state, or federal supports, so that the person can achieve their goals and objectives towards what they define as a good life. So we don't just look at a paper with 7 pages. We go in depth. And today, we're hoping that we'll give you that overview of how the DDA makes that determination. Because as you know, Medicaid will not pay for home and community-based services without a person-centered plan that addresses the person's needs for community services and supports as an alternative to institutionalization. So we want to make sure that the PCP is created using information gathered by the team members, the case managers through an interview, through conversations, to understanding what the person wants to do and the individuals are choosing. So that is, I guess, the base for our conversation today. And then we're going to just tell you a little bit about some historical processes that we thought that you wanted to know about and you may have questions about. So in the past, the DDA has utilized what we call an individual indicator rating scale to identify service needs and funding amount. This system, the IRS, everybody knows it in the community as the matrix score. And the matrix score had 2 main areas: health, medical, and supervision assistance of the person coming into the DD services. And that's how we then determine the level of support and the funding mechanism. So this translated in how we were going to be doing this across the state for day services and for residential services. So a person got 2 matrix scores, 1 for day and 1 for residential, and that's how the budget was done. Since the original development of this tool, new strategies we've been talking about now, planning tools like the health risk scoring tool, the supports intensity scale, and in other identifying information and the team's recommendations to then determine the level of support and hours that somebody may need. So what we really want to emphasize with this slide is that the DDA will continue to use the matrix scores until we get the new funded rates that are established by our rate study. Once we get that, then we will give information out to everyone in the community as to when that will stop and when we'll be starting using the new rates. So this whole process is, I'm just going to give you an overview at a glance. And this is on the left side of the screen. It shows what the legacy process was at DDA for the last 15 or so years. We did initial plan. We did a 30-day review. We did a revision plan and an annual plan. Our new system to the right in that pretty yellow color, we have still the initial plan, the revised plan, and then an emergency revise. And this is for, you know, you came up with a plan and all of a sudden overnight you had an emergency or somebody needed additional services. There's a mechanism of how we can get services to the person immediately with a phone call and then follow-up information. So this is the base. Now, to do that, we have to make sure that the regional office staff are all well informed and educated about all the requirements. And so we'll talk about it. So, and then of course, annual plan. In the regional offices, I assign a program staff person who will be reviewing all initial, revised, in annual person-centered plans. That means everything has to go through the regional office for authorization, and everything has to be done every year. So if this year you have, 10 services, and you realize you don't really need 10 and you won't need them for a while, next year you may want to request 6 services. Same thing with the funding. This year you may have this amount of funding, next year you may not. Or this year you may have lower and you may want to increase. I guess based on increases, they have to be supported by an assessed need. So it starts at home, and it starts to make sure that the regional office staff in the DDA is very well informed of how do we assess and how do we make that determination. And so before I turn it over to Rhonda Workman, these are the main 4 areas that the types of person-centered plans that the DDA has. The initial. This initial is submitted by the coordinator of community services, originally the case manager or coordinator. They submit this to the regional program staff to review for approval and authorization. That's your initial. The revised plan is, hey, you did your initial, but then something changed and you needed to do something different. So this is the ability to make some changes and additions, but if there's changes, there needs to be new signatures and new information submitted, and every service that is submitted has to be tied into an outcome. And we talked about that in the last webinar. And then, of course, any emergency revise. This can only be done by the regional program supervisor, meaning, hey, you had immediate emergency, you don't have time to do all the paperwork, you've made a phone call, we gave you a verbal, and now we have to go back and do the paperwork later. And then your annual plan is required every year by your annual PCP day. And we talked about the annual PCP day the last time too. So this is just an overview of all the areas that we want you to be aware that needs to be in place that we have in the different types of person-centered plans that we have in the regional offices. Okay. Now I'm going to turn it over to Rhonda Workman, who's going to go over the whole person-centered service authorization that happens at the regional office.
So good afternoon, everybody. What we have first on our screen here is just an at a glance of the process that we're going to be talking about in detail in the upcoming slides. So we'll review the review process, the assessment process, clarification process, our consultation process that then leads to our final determination. So let's start with that review process. So we review information because we need to be informed, right? We need to understand the person's story. We need to know what the trajectory is for that person and how they define their good life. We need to understand what the outcomes and goals are that are associated with that good life. We need to be able to understand and see information related to supports and services that that person may currently have. That could be a variety of supports, as Patricia mentioned. That comprehensive person-centered plan should be comprehensive and include all services and supports. We need to be aware if the person has any risk, if there are any restrictions, and then based on that, that's going to help to identify any unmet needs that could be supported with our waiver services. This is a good visual to kind of demonstrate how we look and get information to tell us that story about the person. So we're going to talk about these different areas that are reflected here to include the outcomes. We mentioned that last time. Our focus area exploration is part of our person-centered planning. There's an individual record. We'll explore current programs, our support intensity scale, look at people's rights and restrictions to include behavioral plans if needed, the health risk screening tool, and then other supporting documents. So on our person-centered planning tool that we've talked about last week, there is a summary form. And so in the summary form, it really gives great information about what's important to the person. So as you can see, under important to, it'll identify things that are important for the person. It can be pulled from different information, such as the support intensity scale, or manually added by the CCS. And each item could be associated with a focus area that's explored, and then they can be ranked. And all that's based on the person's preference and choices. We also have information about what's important for me. Also information related to risks, such as potential hazards related to health and safety and welfare, specific actions taken and interventions that may be needed, and even rights restrictions that may be related to an assessed need and how they're being applied. Also in the person-centered plan format, there is an outcomes form, and that outcome form is based on, again, that trajectory. The outcome helps to identify needed services and supports. We recognize that the same outcome can be associated with multiple services and programs, and we require that all DDA requested services must be associated with a specific outcome. If there's not an outcome, then we can't justify why we would be authorizing services. The outcomes do not have to be supported by a DDA waiver service, however. They can be supported by other things such as natural, community, local, and federal programs. And as we shared earlier, remember there's a difference between a good life and a service life, and that should all be considered. When you look at the outcomes, goals, and the supports, they really should all align and be supporting each other. The other area that we talked about last week was the focus area exploration. And as you can see from the visual, we have the various icons showing the different focus areas that can be explored based on the person's choice. Information is learned by filtering through these different focus areas. As we shared, you can choose different areas to focus on. We do require the employment one. And these focus areas captures discussions related to, again, what is important to the person or for the person, what's working for them, what's not working for them, and can help to identify supports to address unmet needs or concerns based on their area they're focusing on. The health risk screening tool is another type of an assessment tool that we utilize that can help to inform us about assessed need. The health risk screening tool identifies risk using healthcare levels, and every applicant or participant should have a health risk screening tool, and it should be accompanying with the person-centered plan. It is required to be done annually, and then when any significant changes that occur, there's some examples listed here. Then on the next slide, some additional information about the results of this tool. So the results of it will issue a score. A 1 to 2 indicates a low risk related to health-related risk. A 3 or above would be considered high risk, and those higher risk requires a review by a clinical nurse before it can be finalized. That will also help to indicate whether there's an increased need for monitoring and supervision because of the person's health risk. Things to consider when we're looking at that is information related to not only the health, but can the person self-medicate, and do they have procedures or treatment that may meet the requirement of a delegation of a nurse. The person-centered plan can be submitted without the health risk screening tool, but must be submitted and reviewed before the regional office can authorize any nursing services and approve that plan. Another tool we use to help with person-centered planning and helping us to be informed is the support intensity scale. So it's part of that person-centered planning process and can help to identify unique preferences, skills, and life goals. This measures the person's supports, needs, in personal, work-related, and social activities. It can help to identify and describe types and intensity of supports the person may require. And in terms of the term supports, this is really referring to an array of resources and strategies, including individuals, agencies, money or tangible assets the person may have, assistive devices, environments that can help people to live in a typical community setting. These are completed for new participants in the DDA waiver after waiver enrollment, and we have a reassessment done on a 5-year cycle. The support intensity scale has some different areas that we can focus on, such as strengths of the person, areas where the person may require supports, areas that are identified for exploration, and areas of interest to the person. Again, the person gets to decide whether these are important to them that they want to focus on with their outcomes.
Rhonda, do you want to tell the audience a little bit about what the screenshots are?
Sure, that's a great question. So what we're demonstrating with some of our screenshots are really screenshots of our IT system, the long-term services and support system of Maryland that we're currently using. So our coordinators of community services and the DDA regional office program staff are able to go into the system and easily access information in order to make a determination on that person-centered plan.
Thanks.
So some other things that we look at to be informed relates to the providers that have been identified by the participant to deliver the services. And one of the federal requirements relates to the community settings rule. And so a community settings questionnaire was developed that is completed on an annual basis when a person changes their day setting, or if there's a change in their residence or living situation, to ensure that they are meeting the definition and characteristics of community in terms of the services being supported. And so for our family supports waiver and our community supports waiver, a person-centered plan cannot be approved if the person's setting is not compliant with the federal settings rule. For our community waivers participants, all providers and new sites that have been approved as of January of 2018 must also be compliant. Generally, our PCPs, our person-centered plans, cannot be approved and services authorized if the person's residential or their day sites are not compliant. However, there are a few incidents where we can approve in these situations. The first one would be when there's a documentation in the plan of supports needs for a modification to the person's community settings rights, and we'll share a little bit more about that in the upcoming slide. The other case or situation would be for the community pathways waiver only when that setting was licensed prior to January of 2018, as those settings and those providers have until March 2022 to become compliant with the federal requirements as per the Center for Medicare and Medicaid Services guidance. So when we're going to approve a setting that doesn't meet the setting rule due to a rights modification, there are additional information that must be demonstrated in the person-centered plan. This includes regular collection and review of data to measure the ongoing effectiveness of the modification of that person's rights, the establishment of time limits for periodic reviews to determine if that modification is still necessary or can be terminated. It includes informed consent of the person and assurances that the interventions and supports will cause no harm to the applicant or the participant. Additional information that we'll explore to be informed of the person and the supports they receive relates to current enrolled programs that they may be receiving. So our system, LTSS Maryland, can give us insight related to the person's whole service story, because now we have the ability to access information about other Medicaid waiver programs and services that people may be receiving. Some examples are the autism waiver, the brain injury waiver, the community options waiver. In addition, we can see information about Medicaid state plan programs, such as the Community First Choice program. There are other services applicants may be receiving: personal assistance, personal emergency response systems, modifications, transportation, therapies, and others that we would also look for information to help us to be informed. In LTSS, this is a visual of information that we can access. So this is demonstrating for this individual that there are multiple person-centered plans or plans of services for other programs, as noted here. So the red arrows are demonstrating that this person is in the CFC, or Community First Choice program, also enrolled in the Community Options Waiver program, and in addition is receiving DDA state-funded services. And so we have an ability to go in and identify the services that they're receiving under different programs to be informed related to whether an assessed need is still demonstrated and needs services under our service system.
It also helps so that we don't make sure we're not duplicating a service.
Absolutely. So that concludes our review process, and now we'll move on to our assessment process. So being informed of the person and their trajectory and the services and supports they're needing, then we need to assess the request and look at it in terms of, is it an assessed need or is it a want? And so some of our assessment consideration, when you think about a good person-centered plan, again, it should be comprehensive and ensure that the person's assessed needs are met through various supports. That includes the DDA waiver programs and other supports we've mentioned in order to achieve that good life. And as we mentioned, Medicaid compliance requires that all services are documented in the plan. So in order for DDA to be reimbursed and pay for Medicaid services, they must be documented in the person-centered plan. So with that assessment, we're going to be considering, again, the whole story of the person. What services and supports are needed? Will the requested DDA services meet those unmet needs, their goals, or their risk? Are the requested services appropriate for the person's needs or their goals? are the requested services within the waiver service definitions, scope, and limitation? And do that requested service support the health and welfare of the person? So with our assessment process, we're going to look in different areas. And so they're demonstrated here that we'll talk about on the upcoming slides. So the first one is the service type. And as we mentioned in a previous webinars, the DDA categories services in terms of 3 buckets: meaningful day services, support services, and residential services.
And we're going to describe in our next webinar in detail of each of those services. So that's our next webinar on the 9th.
So these next slides are just at a glance information about the 40+ services that are available in our waiver program. The chart you would read, FSW will stand for Family Supports Waiver, CSW Community Supports Waiver, and CP for Community Pathways. But here's our meaningful day services that are available as of today. We were going to be transitioning some of the services to our new employment services in July of 2020, demonstrated here. This is our support services. So you can see there are various support services provided. There will be some adjustments based on our amendment that's been submitted to CMS, but this is the current support services that are available as of today. These are our residential services. You can see that our community living enhanced supports will come on board July of 2020, and our new supported living service will start this July 2019. And so in terms of service type, we have developed a service authorization guide. It provides criteria associated with each service that helps to guide our decisions related to authorizing services. This guide is referred to as the DDA Guide to Service Authorization and Provided Billing, and documentation is actually posted on our website with the link here noted on this slide for you. So now let's talk about our service scope. So within each of those services that we'll go into more in depth next week, there are specific service descriptions, service requirements, limitations, and specific service delivery models associated with them. Some of our outcomes and goals we know can be supported by several services. So as an example we noted here, if a person's interested in volunteering, depending on their purpose of that service can be supported, or that activity or goal can be supported with our community development services, rehabilitation services, and personal supports, again, depending on the goal of the person. When you look at our Medicaid waiver programs, there's actually a waiver application that we have posted on our website. If you go to Appendix C of that, here we're demonstrating with the red arrow, there will be a service description for each service. So for this service, personal supports, this is where you would see the service description of the service. The next slide is a demonstration of the service requirements, which is immediately below the service description. And so again, for additional details about the scope of the service and the service requirements, they're all outlined in the federally approved waiver applications. In addition, below the service requirements, there will be information related to any limits that are associated with that specific service, in addition to the service delivery method. As noted here with the second arrow, participant directed is selected, which is another way of saying self-directed services. So now let's talk about service amount. And so, as I mentioned, there's service limitations that are noted in each service, but there's a variety of different service amounts associated with the different services. And some of our services are based on a formal assessment and may have some additional requirements. So as, for example, our assistive technology service is based on an occupational therapist assessment and also consideration of least expensive option. Our environmental modifications that cost over $2,000 will require at least 3 bids. Some of our services also require a consult with the subject matter experts, such as our nursing services. We would be reaching out and working with our regional office nurses, and for our behavioral supports, we would be reaching out to the behavioral leads. Some examples of the different limitations and service amounts. Some of our services frequencies are 15 minutes, or hourly, or monthly, or annually. Some of our services are limited to a specific number of hours, maybe 8 hours per day or 40 hours a week. Some of them are specific to certain days of the week, like Monday through Friday, and some of them have overall total limits, such as $15,000 every 3 years or $500 per participant per year. Again, those are all outlined in the service limitations. In our service amount, the Meaningful Day and Residential Services, again, as Patricia mentioned, we'll be using that DDA matrix to continue to identify service need and funding associated with that until we get to our new rates. So let's talk briefly about our service providers. So service providers are all specified in our waiver applications, and there's specific provider and staff qualifications that must be met initially and continuously met in order to provide our services. Some of our services may have more than one type of provider listed, and providers can be community agencies or individual professionals or direct care professionals. We also recognize and want to share with you that people self-directing can also identify and use individuals, agencies, and providers that are not licensed or approved by the DDA based on the approved waiver specific services. The provider specifications and requirements are also listed in the federally approved waiver applications. It's noted in Appendix C. It immediately follows the limitation section, and it'll specify the provider in terms of agency, individual, and also get into details about the specific requirements. As we mentioned before, providers must meet that community settings rule requirements, and that all family supports and community supports providers must be in compliance. And all providers approved or authorized as of January 2018, they also need to be in compliance. For the Community Pathways waiver, providers that have been providing services prior to January 2018, again, will have until March of 2022 to meet the requirements. The qualified provider types, you'll see, will vary based on service. They include licensed providers, which are provider-owned and operated site-based services, such as day hab and community living. Our DDA certified approved providers, such as respite care, nursing services, and others. We also have organized healthcare delivery systems that are able to have contracts with non-Medicaid providers. We also have individual professionals, such as a licensed nurse that may want to provide our nurse consultation, and also self-directed staff, agencies, and vendors based on the self-directed model. Staff qualifications are also listed in our provider qualifications within each of the specific services. Some of them may have additional requirements, such as attending training. So we put on this slide some examples related to some services, such as the requirement for CPR and first aid, criminal background checks, and if there's administration of medication related to med techs. For employment services that are coming up, we're looking at competency-based training and employment certification. And our nursing services require training with the HRST, completing of our DDA case management delegation nurse orientation, and also being active in the DDA registry for nursing case management delegation and others. So the next section is signatures. So part of our assessment process, we're going to look to make sure that that person-centered plan that's been submitted on behalf of the person has their signature or their authorized representative signature telling the DDA that they're in agreement with those services and supports that have been outlined. It also requires the coordinator of community services. And if a provider is listed in the plan, then they're also required. As we mentioned last week, you can submit a plan without having a provider as long as the service is identified. If the authorized representative a signature page is required, if the person has to have that, and if the case of a signature page from a person is not required to submit the PCP because their authorized representative has authorized on their behalf. All signatures must be current and updated when there are service change. So during that revised plan process, if there's a revision to the service, then the provider that is associated with that will need to sign that, and the participant or their authorized representative and coordinator of community services would also need to sign and have a new signature page. So that completes our assessment process. So let's talk a little bit about the clarification process. So during our process to be informed and when we're reviewing and assessing information, There may come times when we may have some additional questions that we need to get some information. And so when we're assessing that, we may reach out to the coordinator of community services or the team through what we call a clarification request. All communication regarding that person-centered plan should be documented within our clarification request section in our LTSS Maryland system. Our clarifications requests should be clear and detailed and specific to the person and plan and be unbiased. Our language will be fact-orientated, person-centered, and it's not meant to negotiate waiver services. It's really meant to capture information, we want to avoid discussing needs in verbal discussions and emails unless absolutely necessary, because we really want to have that documentation of the assessed need and support of that through a formal process. So if in the event there are some verbal discussions, then we will be asking that it be documented in the LTSS system in the clarification request. Some examples of some of the information that we may seek out for clarification are noted here. We may seek a clarification because the assessment that was provided doesn't support the hours requested, doesn't support the need. We may ask for clarification because there's missing documentation, such as an assessment, the behavior plan, the health risk screening tool. Maybe it's the assistive technology assessment or the environmental mod 3 bids that are required. So when we're looking at clarification or missing information, again, these are just some examples that could be submitted. The difference between clarification requests versus denial, it is our hope and our goal to seek clarification and get resolution and information so that we have all the information to be informed to make a determination instead of quickly making a denial that then would require the whole process to start over. So if missing information or additional clarification is needed where we feel we could get that person-centered plan approved with those changes, then we're going to send out that clarification. But if there's so much information missing that the region is unable to even begin the review, then they really have 2 options. One, to send out clarification requests, and it could be multiple ones, with comments such as, we're unable to render a decision on the plan due to missing information, please upload or provide various information. Or they could deny with the note that the PCP documentation was missing information related to those things. But again, our hope and goal is that we get a complete, comprehensive plan from the get-go so that we're able to make a decision timely. So let's talk a little bit about our consultation process. So as I mentioned before, some of our services require some additional information and teaming up with other subject matter experts. We do this through what we're calling consultation requests. So for all nursing services, we're going to reach out to our subject matter experts, our regional offices nurses, and we're going to consult them related to the request for nursing services and the assessed need. They will review the health risk screening tool and other documentation and advise the program staff. For our behavioral support service request, we're going to do the same thing, but we're going to reach out to our behavioral support service leads because they're the ones that are the subject matter experts related to our behavioral support services. And so now we get to the determination process. So we've reviewed information, we've assessed information, we've sought clarification, and we've also sought consultation. And based on that, then we're ready to do the determination. All of DDA service requests, service authorization, requires service authorization and approval, basically a determination in order for that PCP to move forward. The determinations are based on the person's plan and the assessed need, which would be documented as we do our review and assessment process. And the assessed need must be in accordance with the established service descriptions that we talked about, service requirements, and service limitations. Determinations are required for all types of person-centered plan, as Patricia mentioned earlier, initial, revised, annual, and emergencies before our services are delivered. And again, Medicaid will not reimburse for services without documentation of the service authorization. So a specific service authorization is based on the specific service description and instructions, criteria that we mentioned outlined in that guideline for service authorization and providing billing document that is available on the DDA website. The amount of service is based on the service-specific limitations that are noted in the approved waiver and also recorded in that service authorization document. We'll also be looking at typical or customary service amounts, so typical amounts authorized for most people. We're also going to consider whether the service amount requested is reasonable. So that would be justified based on the documented unique person-specific needs, because we're all different and have different needs. And for some of our services, there may be consideration of the most cost-effective service, such as personal supports versus supported living. Our services, rates, and units, again, will be transitioning within the next year as we move fully with our full services and the rate study. So our decisions and determinations based on that assessment and review, we are able to issue an authorization and approval determination when all of these requirements noted on this slide are met, that the services address an assessed need, that they're linked to an outcome, they meet the service criteria, they're within the service scope, that they are available within that service model, whether it's self-directed or traditional, that requested amount and frequency meets the criteria established in the federally approved waiver, that there's no duplication of services from other programs, that the provider is appropriately licensed or approved and also community setting compliant as applicable, that all appropriate signatures are present, and that the person's health and welfare needs are being met. So again, in order for us to make a determination and approve a person-centered plan, all these elements must be demonstrated in our review. And so for decisions where we would deny a person-centered plan, again, we'll first seek clarification, but based on the clarification in our assessment, if we determine any of these indicators, so if one of these indicators are not present, then we must deny the plan. So it's basically the opposite of the approved. So if waiver services do not address an assessed need, the waiver services are not linked to an outcome, the waiver services do not meet service criteria, the waiver services are not within scope, they're not available in that service model, that the requested amount frequency is beyond the scope of the waiver services, that the services are duplicative of other programs such as CFC and other programs, if the provider, if they're listed, is not approved or licensed, if all appropriate signatures are not present, and if the person's health and welfare needs are not being demonstrated to be met in the plan. So again, if any one of these things are missing, then the plan would be denied.
But we would get clarification, like if we're missing signatures, we'll try to get the signature before we deny it.
So PCP denial decisions that we'll be issuing will be clear, specific, and concise. Some examples of the language that you may be seeing is waiver services are not meeting the service scope and documentation of duplication of services. A person could be receiving 85 hours a week of personal assistance through CFC, and then we're also requesting personal supports to assist primarily with ADLs or IADLs, which is considered a duplication of services. Another example could be that the request for 65 hours a week of CDS is beyond the scope of the waiver service because it's limited to 40 hours in a week. So just again, to kind of review at a glance, we will, with person-centered plan and all the supporting documentation that we receive with it, we will review all that information to be informed of the person's whole story. We're going to assess various information that we've talked about in the slides. We're going to seek clarification if we're missing information, need additional information, or have questions before we would issue our determination. We're going to consult with subject matter experts related to nursing services and behavioral support services, and then we would issue our final determination. So as we've shared on our previous webinar series, in terms of the process at a glance, what we talked about today relates to the waiver packet and the person-centered plan that's in it. So in order for the person-centered plan to, or the waiver packet to move forward or be authorized, or during that annual or revised person-centered plan, we would complete the processes we talked about today.
So this concludes our webinar. We're going to open it up to questions and answers, but I just wanted to emphasize that the April 9th webinar, we literally are going to go through the slides that we went quickly today in reference to the waiver programs, the application for that, and how we submit the waiver application for approval in the specific services. What do the services mean? How do we interpret them in detail? And then we're going to go over between what a traditional services, self-direction, budget authority, and employee authority. So we'll go through that. So I'm going to open it up for questions. Let me go here. Can't find the questions.
So bear with us. We're just trying to open the screen so we actually can see all the questions. Hang on a second. Okay, so we've...
Okay, so here we go. We're getting to all the questions. So asking for clarification, these tools are used after waiver has been approved?
So that's a great question. So let's regroup on what we're talking about today and just review. The Coordinator of Community Services will be assisting the individual and their authorized representative, their family members, their circle of support in developing a person-centered plan. And that's what we talked about last week, was the person-centered plan and the different elements related to that. That plan is then submitted to the DDA regional office and reviewed for authorization, because in the plan, if there are DDA funded services or waiver services that we're going to talk about next week, they all have to be reviewed and approved and authorized in order for those services to be delivered and the provider to do services. The process we talked about today is the process that that plan will go through, and in terms of what DDA will review and making their decision. So the process today is what DDA regional office staff will do in terms of reviewing, assessing, seeking clarification, consulting, and making a determination.
Who is responsible for completing the support intensity scale?
So that's a great question. The DDA has an independent contractor that completes the support intensity scale. They have to be certified and trained in the tool in order to do that.
Is PCP on LTSS accessible to participants and family in support broker, at least to read mode?
So that's a great question. Currently, that is not available. With our long-term services and support Maryland IT system, it's being implemented in phases. So right now, the Coordinator of Community Services has access to it to enter information and view, and they are responsible for ensuring that they share printout copies with all participants and their team members in order to review.
Can you expand on the federal standards for the community settings rule?
So that's a great question. The federal government issued guidance related to what they feel are meets the definition of community, and that services that are being provided need to be provided, and people need to receive services in the way that are similar to people who are not on Medicaid programs. For example, individuals that may be receiving residential services in our community living service programs have the same rights that you and I have today. So if I were renting a place or in an agreement with a group home, I have the right to have visitors, I have the right to access food, I have the right to lock my bedroom, I have the right to decorate my room. And so it's looking at those same type of requirements being applied to all home and community-based services as rights that we all have in our lives today.
Is supported living approved to start on July 2019?
Yes, supported living services will begin July of 2019.
So who is the BSS lead for CMRO and ESRO?
So that's a great question. I would start with contacting the regional office, and they can connect you with the specific staff that are associated with that.
It also depends on the question, because we can have Dr. Di Pasquale also. So we team up to see who would be the best person to answer that clarification of that question. Try to read this one. I've noticed some signature pages that did not have services listed. It was just blank page. Please make sure that this is filled out before having participants sign.
Oh, absolutely. So all signature page should have information about the specific services. Individuals, family members, authorized representative, providers, you should not sign a blank page. You should never sign anything blank, whether it's an invoice, timesheet, or a signature page for the PCP.
How about things like clubs? For example, my daughter belongs to a social club for high-function individuals. They focus on living skills. They won't be a certified provider. It's more of a co-op model.
So as we mentioned, the person-centered plan is meant to be comprehensive. It does not have to have a DDA-funded service with every outcome. Remember, we shared that outcomes can be on a plan, a person's goal and trajectory, that do not need DDA services. So people attend clubs, they go to faith-based services, they do a variety of things, recreational, social things that are not associated with state-funded services. So if they're not being funded by the program, then they would not need to be approved or certified.
Would you be able to share an example of a person-centered plan to get a better idea of what it looks like? A name could be crossed out or more, just so we can get some more information.
So that's a great suggestion. We'll look at that and see what we can do to provide maybe in an upcoming webinar series.
Yeah, we are partnering up with the DD Council to provide training to families and individuals, and we're also providing training to the coordinators of community services on person-centered planning. So hopefully we'll get to do that as well. Is there a way to download this so that we can go through this slides slowly at our own pace? Absolutely. We are putting, actually the slides are here that you can, to your right of your screen, it'll say presentation, you can print it, and we're also posting them in DDA's website under training and webinars. Is the coordinator of community service the same as service coordination?
So the Service Coordination, Inc. is one of our providers of coordination and community services. So they would be an agency that's providing that service.
Can you give an example of an outcome in service that match? Is there other places to find this example?
So that's a great question. And if you were able to join us last week, we talked about outcomes. And that we used personal outcome measures and other strategies in the plan. But for an example, let's say I want a job, so an employment would be my outcome. So one of the services that I could seek related to my assessed need could be employment discovery and customization, or supported employment, because that would be supporting my goal, my outcome for a job.
So I want people, if you guys get an opportunity to look at the screen under handouts, it says 2. If you click on there, you'll see the presentation from last Tuesday, and you'll see the presentation from this Tuesday. You can print today as we are online. And we are working on posting everything to our DDA website through our IT departments, and that's taken us a little while, so just give us until the end of the week for us to have that there. Can you please talk about supported living? Join us next Tuesday, and we're going to talk about each service in detail. Are there any differences in PCP, if a PCP is for someone who is self-directed versus provider-based?
So that's a good question. We require a person-centered plan, our new person-centered plan format for all people regardless of service delivery system. People who are self-directing can then utilize different budget strategies and tools to outline how they're going to oversee their program.
Can you address what specific information is needed for the scope we are mixed groups of CCSs and provider staff?
So that's a great question. We're going to be providing additional information and guidance related to scope and some upcoming trainings, specifically for our CCSs and provider staff. Given the interest of time, we only have a few minutes left. I think we'll just we'll look to follow up and provide additional guidance for our CCSs.
This process seems overwhelming to families. Is there a checklist of things that you need to do to complete the process, for example, self-direction? So this is what we wanted you to understand with this webinar. It's really what goes behind the scenes and how the DDA approves the plan. All we would want is the family and the person and the CCS to truly give us a picture of the person, their supports and assess needs, and have that information to support that. The DDA will do all the background work that Rhonda and I was sharing, like looking at the scope, the service, the duration. That is what we will do. So we would want to make sure that that information is in the background. What is a family as a person in services will need to do is, hey, I need the services. This is my assessed needs. This is how I can support it. This is how I match to my outcome. And this is what I want, or my daughter or someone's, for the trajectory to a good life. How do you make it happen? And so what we're sharing is the back scenes of what happens with that. What is the difference between matrix score and CIS, and what is the order of this being done during the individual's initial DDA application process?
So that's a great question. So the support intensity scales are being completed after the person is enrolled in the program, in the waiver program, and then will be completed on a 5-year basis. The matrix score is being completed when people have been authorized the funding.
So why does DDA still refer to traditional services versus provider-based services, and why the complete separation of traditional and self-direction services? Actually, we don't, but we know the audience, when we don't say that, they'll say, well, what happened to self-direction? Where are we included? And so we really are saying our services is one model. There's an option for self-direct, but when we don't do that, we get questioned. So we want to do that so people know that traditional services, we have 2 models, traditional and self-direction. Great question. I'm just looking to make sure they're all specific to today's presentation. Will community options waiver be discussed in detail next week, or how I can get information about it?
So the community options waiver will not be discussed next week. The DDA administers 3 of Maryland's 8 home and community-based waiver programs. The community options waiver is oversight and administered by the Office of Long-Term Services and Supports, and Lorraine Nawara would be the contact person for additional information.
How does the regional info form in requesting self-direction fit into individuals' initial DDA application process?
So that's a great question. Today, we are talking about the person-centered plan process. So that's something we could probably talk about and add to our self-directed services webinar.
How long does it take to determine the matrix score? I have been waiting for over 2 months. That's a great question. We usually submit it to the vendor, and then they have to then contact the CCS and the family and the person to schedule. So it should not take more than 3 weeks to coordinate that appointment.
So we suggest you contact the regional office to follow up for some assistance on that.
So the question goes back to the same family, but will DDA pay for some of the costs involved with the club?
So no, clubs and recreational activities and things like that are things that we all do, whether in Medicaid services or not, that we would use our own personal funds for. As we shared in previous webinars, there are a variety of different free information or free programs, free activities that are available. And so Medicaid dollars are not used to pay for activities.
What information and what source of information does the independent contractor have access to in order to make their assessment? Do they ever have firsthand input from the person or their family?
So I think you're referring to the support intensity scale, and yes, so they would be meeting with the individual and the family to gather that information.
It is 1 o'clock, and I want to be respectful of the time that you have with us. And so we did not get to all the questions in today's webinar, but we really do thank you for joining us. We had over 219 people today, so really appreciate it. And then, I'm sorry,
261.
I'm sorry, 317 people together. So thank you very much and have a great day.